Hi, it's Dr. Centeno, and welcome into You've Got the Power. We're going to be talking about an interesting topic today. As you know, I often blog about, do Facebook Lives about things I experience on a day-to-day basis. I see patients and do procedures during the week. So patients come in and, I see what's occurred and then get an idea for something to talk about. So in this case, this was a patient who had come in this week. And it was interesting because I think that once I explained to her what had occurred, she had a posterior decompression for Chiari. And she was very savvy and certainly understood all the different parts and pieces that we were discussing, how that impacted some of the treatment options going forward. So I'd like to get into that today. How does a posterior decompression for Chiari impact things? In particular, one of the things I think she was very surprised about was this concept that occipital nerve blocks, which seem to be such an easy thing to get, and it's a common treatment in a lot of patients, could be particularly dangerous based on what had been done. So we'll get into that today. As usual, I will give a short presentation, and then after the presentation, answer questions, whether it's about this or any other topic. Again, just to go over what we're going to be talking about today, if you're just joining us now, the topic is going to be what happens to the anatomy as a result of a posterior decompression surgery for a Chiari malformation, and how does that impact the options that that patient has going forward for regenerative medicine or even something as simple as an occipital nerve block. So let's get into that here without much further ado. I'm going to go ahead and share my screen first. And then I will go ahead and we will start that presentation. So the presentation is what happens as a result of a posterior decompression surgery for Chiari, why blind upper cervical injections are not okay in these patients. And this is based off of some of the things that I saw this week with this particular patient. And as I explained this to the patient, even though she and her family were very sophisticated in what they understood about all of this, I think this is not something they had considered. So I wanted to get it out there. So we have a couple different things to understand. So a normal brain has the entire brain that's encased within the skull, as you can see on the far left there. And that dashed line is at the foramen magnum. So in Latin, the foramen magnum literally means big hole. So it's the big hole at the bottom of the skull. And normally it's just the upper cervical cord and then the cervical cord that passes through that foramen magnum. In a Chiari 0 patient, the back part of the brain, as shown in the middle, touches the dotted line that goes across that foramen magnum, and that's called a Chiari 0. It's also called cerebellar ectopia, and as a general discussion of when the back of the brain hangs too low. And then as the back of the brain, as shown in the far right, starts to get too low, and it descends more than 5 millimeters below that artificially created dotted line that goes across the foramen magnum, that's called a Chiari 1. So that's what Chiari malformation is. And you've probably heard about that if you have CCI or if you've been talking to others in this space, you've probably heard about Chiari malformation. So that's what that means. Now, the interesting concept is what percentage of people have Chiari on their imaging but are walking around with no symptoms whatsoever? And does the severity of Chiari malformation actually matter when it comes to surgery? So the first study I have there is an interesting one. Now, these were much more severely affected Chiari patients than I normally see, meaning the average was 11 millimeters, not just 5, below that foramen magnum. And most of the patients I see are in either the 0 to 5 range, and I see some in the 0 to 10 range, but I rarely see patients that are in the 11 or the 10 to 15 range. So that's where these patients were. 14% of those patients didn't have any symptoms. And so that's pretty good predictive power. 86% of them did. But again, that's a much more severe Chiari than I commonly see. And then we have an early study from the 1980s that seems to suggest that 2 to 3 millimeters below the foramen magnum identified patients versus asymptomatic people. Now that one's a little bit aggressive, right? Because it seems to suggest that if you've got a Chiari 0, then that should be causing symptoms and that we could identify that solely based on an MRI. I realize the MRIs at the time were pretty nascent. And unlike today, upright MRIs didn't exist back then. And then we've got the third study. The severity of Chiari malformation didn't correlate with symptoms at all. That's a newer study. And what was interesting is the 0 to 3 millimeter below group had more pain than the 3 to 5 and more pain than the greater than 5. And then finally, a fourth study that shows there's no relationship between the severity of Chiari, whether it was 0 millimeters or a 0, 4 millimeters, 7 millimeters below, or 14 millimeters, and surgical outcomes. So it's kind of all over the map, right? And this is one of the reasons why I tell patients with Chiari malformation that this could be causing some symptoms, or it could have nothing to do with your symptoms at all. So is there a better way to predict which Chiari patients will have symptoms? And the thing that I've seen most recently that makes the most sense is the research that shows that the C0, C1 joint is normally cup-shaped, but some patients have a flatter joint, as seen on the far left there. And this means that they rely on intact and normal upper cervical ligaments to provide stability. So for instance, if you've got a joint like the one on the right, shown in D there, and there's a deep ball and socket joint, that joint is going to provide a lot of stability at C0, C1. But if you've got a joint like the one on the left, as shown in A, it's not going to provide much stability. And if those ligaments are injured up there, you're going to get a lot of motion between the skull and the atlas. And in fact, when they looked at symptomatic or asymptomatic patients, this did pretty well in predicting which Chiari patients actually had symptoms. And it makes sense. You got the brain hanging low, and then you've got instability on top of that. And so the two together, meaning Chiari plus CCI, are the folks that had symptoms. So that's why I always tell patients, if you've got a Chiari malformation and you've got CCI, it's just like adding gas to a campfire, right? It's an accelerant, if you will. So what happens during a decompression surgery for Chiari? So this is a patient who I saw in the office, and up in here is the bone that's been removed. So that's the back of the skull. As you can see, a lot in the midline, quite a bit of the back of the skull has been removed. Again, the yellow dotted line is where the skull should be. And we see that the dura shouldn't exist below that, but it does now. And the dura is where the white is below that yellow dotted line. Now, what was removed? Well, they took out, in this patient, the yellow part in the bottom right here at the skull. They took out the back of the atlas. Now, in this patient, they didn't remove the back of the axis, but sometimes, or C2, but sometimes that's removed. They also end up doing damage to quite a few muscles that attach to that bone because muscles can't survive once you take out the bone that they're attached to. So those are important upper cervical stabilizers. They also take out that posterior atlanto-occipital membrane because that's attached as well to some of this stuff. So at the end of the day, quite a bit of structure is removed. And what replaces the bone? The most common thing I've seen is this type of titanium mesh. And the titanium mesh as seen here has got holes in it. Now, why does it have holes in it? It has holes in it to try to allow it to integrate tissue better. So the concept would be that at some point, hopefully some tissue will grow in there. It's not going to be bone, but it's going to be soft tissue that would grow in that area. And so at the least, you'll have some coverage there. It's nothing like, a very thick bone, but at least there's some coverage in the back part of the skull and brain there. Now, this is the patient I saw, and this is why I think it's important to talk about this. Because the patient walks in, she had a Chiari decompression surgery a couple of years back. She thinks they injured the occipital nerve during the procedure, because after the procedure, she had much worse and different headaches. She's been struggling with those headaches for years. And one of the strategies that she uses is to get a blind occipital nerve block every few weeks to help control these headaches. Now, there's a substantial issue here, however, and something I'm hoping that is becoming obvious to you as I talk about this, right? Because we now have this mesh that replaces part of the skull. And in doing an occipital nerve block, you can see the direction that goes. If you're doing it blind, and that's the red arrow, you've got to inject up against the skull, hit the bone in the right spot, inject there, and then inject as you pull back in order to block the occipital nerve. Well, if you don't have strong bone there, and all you have is this mesh, which has holes in it, you're risking going too far. And if you went too far, you would be just a little bit, you would be in the dura, and you'd be injecting that anesthetic into the cerebral spinal fluid, which is going to cause some very serious issues. Now, if you go really too far, you're going to park this needle in the cerebellum, which is also going to cause some very serious issues because you're sticking a needle in someone's brain. The biggest issue is that immediately that you're going to have to deal with is this patient is going to go completely out. She's going to lose consciousness if you inject inside the dura into the cerebral spinal fluid, and she's going to be unable to breathe on her own for 4 to 12 hours. Now, if she's in an office that has a full crash cart set up and knows how to use it, then they'll need to do emergency intubation and obviously hook her up to oxygen and bag the patient or give her artificial respiration during that time. Now, if they do that within 4 minutes or so, 5 on the outside, then she's going to be fine. It's certainly going to take some elbow grease. You're going to have to bag this patient for a long time, but she'll eventually wake up, eventually be able to breathe on her own. The problem is that if you don't do that within that 4 to 5 minutes, or if you don't have that equipment in the office, which a lot of medical practices don't, because they don't use oxygen for anything like we do. We use it all the time because we're using it for anesthesia during procedures. But if they're not doing those procedures, they may not have any oxygen. It's certainly not enough to last 4 to 12 hours. They may have enough to do 15, 20 minutes in a crash bag or a crash cart, but they're not going to have 4 to 12 hours worth. So as you can see, there's some pretty big issues here, a lot of ifs to make sure that that patient stays alive. Now, bupivacaine as a long-acting anesthetic is also neurotoxic. So there may be some residual brain injury as well. And obviously, if you inject directly into the cerebellum, there's definitely going to be. So as you can see, this patient really didn't know this, despite being very sophisticated in her knowledge about what was going on with her, what had been done, why it had been done, etc. And the doctor performing these blind blocks, I'm assuming, never looked at the MRI or the imaging and didn't understand that there wasn't like a plate there. In fact, I think her father was a physician, and his conception of what was there was it was a plate. Makes sense. Plates used to be really common. They're not as common these days. So I don't think anyone understood that this was a mesh there, certainly not the doctor doing the blocks. So if you're going to get occipital blocks in this area, you would need to do that under precise imaging guidance. Ultrasound would be the best so that you're staying away from those areas. And then finally, obviously, for any regenerative medicine stuff, lots of structure has been removed. So she may not be as good a candidate for any of that stuff. So in conclusion, Chiari decompression removes key structures. Obviously, that can impact things like PICL, posterior injections, success, et cetera, because you're removing a lot of the stabilizing structures, both passive and active, like muscles. And the Chiari decompression leaves the back of the brain unprotected from needle sticks, because usually it's a titanium mesh that's put there where the needle can go right through one of those big holes. And anyone who's had this kind of surgery can only get imaging guided upper cervical injections from a provider who's highly skilled and understands that these structural changes have happened. And clearly that wasn't the provider. She was seeing the provider at the local university, would seem to be pretty safe, but apparently that due diligence was never done. So my advice to this patient was no more occipital blocks until you can find someone who does this with ultrasound guidance, someone who understands how the structure has been changed and what the risks are, and preferably someone who's got all of that equipment in their office. So if something were to happen, it moves into the you're still okay zone versus you're dead zone, which is something that can happen if that equipment's not available. So let me now go to some questions. We'll see if we've got some questions here. Let me stop my share. Looks like I got it going there. Okay, Rishi, I'm coming to see you in a couple of months. I'll move this in the middle here. Coming to see you in a couple of months and have my DMX already booked with CATs. Would it be helpful to also get up-to-date upright flexion extension MRI? Could potentially help my treatment plan with you and give more information. I know you say would never turn down more information, but I wouldn't want to waste money on this. Yeah, Rishi, I do say that I would never turn down more information. It's always better than less. I'll look at all the imaging myself. I can only tell you the likelihood that it's going to change the treatment plan. DMX is the most likely to change the treatment plan. Then we've got upright MRI. Then we've got a cervical MRI. So let me just put it this way. What are the odds that if you got it, meaning got the upright flexion extension MRI, it would change the treatment plan in such a way that we'd be doing something substantially different than what we had planned with just the DMX? And I'm going to tell you 1 in 20, somewhere in there. So that's the best I can say. I wish I could tell you more exactly, but obviously everyone's different. And I wish I had a better answer, but hopefully that helps you make that decision as to whether or not that imaging is worth it to you. Rishi, if the patient suffers from mild insomnia, will this make it more difficult to put the patient asleep during PICL? Also, how do you monitor if someone's going to wake up mid-procedure, stop this from occurring if the patient's head is strapped in place during the PICL for any movement of the patient? Yeah, Rishi, so when it comes to insomnia, unless you're taking some aggressive medications to get to sleep, or things like kratom or CBN or CBD or THC, it's not going to affect the procedure or anesthesia. As far as making sure someone's not going to wake up, we're consciously monitoring all of that. We've never had a patient in more than, I think we're up to about 1,200 procedures now, that has moved in a way that has made them substantially at risk. Now, there are certainly times where we've had a patient move and I've had to take out the needle to make sure I was protecting the patient, that kind of stuff. But as far as securing the head, it's not really very practical for what it is we're doing, simply because many of our CCI patients have a real hard head is placed in any one specific position. for too long. So we try really hard to work with the patient on getting them sometimes splitting the hair, if you will, or threading the needle in such a way that the patient's head is in a reasonable position for that patient, but we're still able to get where we need to go. Daniel, by what mechanism does a plate lysate epidural help healing bulging discs, and by what mechanism would it provide temporary relief? Platelet lysate, it depends on how we're using that. So if we're talking about a platelet lysate epidural, so just so that everyone understands, platelet lysate is when we take platelet-rich plasma or PRP, we break open the platelets, we get the growth factors out, and that's what we're using is the plasma with the growth factors without the platelets. As far as how that's used, we can use it epidural. So that's going to do things like help the nerve, speed up the process of getting rid of a herniated disc, that kind of thing. When it comes to bulging discs, if we want to try to help that problem, we would also treat the functional spinal unit, which might be the muscles at that level, the ligaments at that level, in addition to epidural or around the nerve and or into the joint. Now we've got a situation where we're improving overall segmental stability, and that can help the disc long term. If the goal is to get rid of the disc bulge, which we can do, that's a Grand-Cayman only type procedure in general, where we inject hypoxic conditioned cultured mesenchymal stem cells into the disc annulus. Daniel, is C1-C2 fusion better than C0 through C2? C1-C2 is the hardest one, I think, to get fused because 50% of your neck rotation comes from C1-C2. C0, C1 is a little different. That's a chunk of your nodding. And most people can do with getting rid of some of their nodding, but I think a harder thing for most people is if we suddenly get rid of 50% of your neck rotation, that can become functionally disabling. So I would say there isn't a huge difference between 0-2 and 1-2 because of that when it comes to how patients will perceive that functionally, at least in my experience. Submitted advanced by John Gardner. Hi, Dr. Centeno. I believe I have craniocervical syndrome. Every time I work out, my symptoms return. Can I lift weights with CCS? Or is it my disc bulge C5, 6, 6, 7 causing irritation? Yeah, I couldn't answer that question just by reading that question. I can tell you that if you've got craniocervical syndrome, that's more likely to be associated with things like headaches, dizziness, imbalance, brain fog. The lower cervical spine would be associated more with things like pain in the upper back, neck pain, numbness and tingling down the arms, that kind of stuff. So hopefully that helps. Rishi, how do you inject the trigeminal nerve? Is this done through the cheek? What size needle is used? And are you put to sleep for this? Rishi, we generally don't start with injecting the trigeminal nerve. There's really no reason to in most CCI patients. We treat the CCI first. Now, if for some reason the trigeminal nerve still needs to be treated, there's a number of different types of injections that can be done, like a V2 Caesarean ganglion versus treating V1, etc. So a lot of that depends on where we are, but that's an X-ray. So for the middle V2 one, that's an X-ray guided injection that's done with contrast to make sure that we go into the area where the trigeminal nerve comes through the skull. And yes, patients are generally put to sleep for that. What size needle? Usually a 25 gauge needle. Is it done through the cheek? Yeah, kind of. So that's more information on that. But generally don't start there because most of the patients' trigeminal neuralgia symptoms will go away if we treat the CCI. Now, that's not everybody. Sometimes we need to then go back and treat the trigeminal nerve, but it's all risk versus benefit. So if you're looking at risk benefit, you expose the patient to the least risk. That's the most likely to work. And if that doesn't work, you go to the higher risk procedure. Daniel, when do you start injecting the transverse occipital ligament and Barcos? I looked at my procedure notes. Those ligaments were not listed. Yeah, we generally don't routinely inject the TOL or Barcos. We can target those if we've got a specific concern about those ligaments, but we generally don't routinely target those. Daniel, what's your recommendation for a patient who can hold AO for a couple of weeks at a time? Not sure what you mean by my recommendation. If what you mean is someone is functionally disabled and can hold an AO adjustment for a couple of weeks at a time, then we're going to be looking at treating them. If someone is fully functionally capable and they can, let's say, every couple of weeks go out and they get a quick chiropractic adjustment, goes back in, and they're back to normal, then we've got to really think about risk benefit. Does it make sense to treat that person? Always what we try to look at is risk benefit. How functionally disabled is this person? What's likelihood of helping that person, et cetera, et cetera. Regenetics been advanced by John Gardner. Hi, doctor. What ligaments or discs do you inject exactly for CCS, and how many treatments typically does it take to see the results? I know results vary per person. Usually, not discs. Usually for craniocervical syndrome, it's the upper cervical facet joint, 0, 1, 1, 2, 2, 3. Might also be things like the C2 dorsal root ganglion or the greater occipital nerve, third occipital nerve, or lesser occipital nerve. Those are sort of the things that we would treat. Biomechanically, how does the curve correction therapy restore the neck curve without overstretching ligaments? Yeah, you want to overstretch some of the ligaments that are and/or muscles that are tight and preventing the curve from being normal. But overstretching ligaments is sort of the point here. Now, obviously, you don't want to make them too loose. And if you did, you'd have to follow that with some ligament injection. So we'll commonly support the posterior ligaments while someone's getting curve correction through injecting those ligaments directly. Rishi, what are your thoughts on orthokine, regenokine? Is there any good evidence that this works? There's a place in Germany that offers this. UFC Boston has said it cured his Meniere's disease. However, I'm skeptical of this. Yeah, let's see. I published on orthokine. Years ago. Let's see if I can pull that up for you. Let's see here if it comes up. I might have it at a regenokine. Regenokine is what they kind of called it when it came to the US. So orthokine, regenokine is a procedure that increases IRAP levels, interleukin receptor antagonist protein. For some reason, it's not coming up, but they have kind of messed with the website a little bit. Bottom line was, when I looked at the knee osteoarthritis data, it was barely beating placebo, so it would be less effective than platelet-rich plasma, and much, much less studied than platelet-rich plasma. So you'd be much better off with platelet-rich plasma than IRAP, which is orthokine, regenokine. As far as treating Meniere's disease with it, I'm not even quite sure how that would work, unless the Meniere's disease was specifically due to some structural problem, something like C2-3 facet osteoarthritis, and it wasn't really Meniere's disease, it was cervicogenic dizziness, and they treated that specific joint. But I'm not quite sure how you would treat Meniere's disease with an injectate at all. Amen. Centeno did a rotational CT and found 30 degrees right and 40.8 left. Is that considered C1, C2 instability? No, it's not. So the official number is 56 degrees based on a study by Dvorak. So certainly up to about 42, 43, 44 degrees is still normal motion, because you have to realize that C1, C2 supplies 50% of your neck rotation, and the normal young healthy adult gets 90 degrees in total. So 50% of 90 degrees is going to be about 45 degrees. So anything below that's going to be totally normal. And then you've got the concept of hypermobility, and that's generally considered at 56 degrees. So if it were, let's say, 50, 51 degrees, 52 degrees, now we're getting into the hypermobile C1, C2 range. Rishi, do you have high success rate with treating trigeminal neuralgia? How difficult is this to treat? It's just higher risk to treat. So there'd be no reason to treat it in a CCI patient out of the gate. We'd want to treat the CCI first. Rishi, does waiting a year between PICL procedures affect outcome and results? We had that Rishi sort of natural experiment that happened during COVID, right? We had some patients that hadn't come back in for a year or more, kind of 1 to 2 years because of all the pandemic related stuff. Ultimately, that caused some problems because, and I would say about half of those patients substantially regressed because they weren't getting ongoing treatment that they needed, and half of those patients kept their gains. So I'd say it's 50-50 on waiting a year based on what we found out during the pandemic. Daniel, is a unilateral CCI easier to treat? Not really easier or harder to treat than bilateral. Finn, this is hard to articulate, but if CCI is too far forward and compressing the IJVs, can PRP injections tighten the posterior ligaments and pull C1 back, or you need to adjust the atlas back? Yeah, Finn, I think you're thinking about it or conceptualizing it in not an anatomical, physiologic way. So as I've said, IJV compression is incredibly common in patients without symptoms. So for example, about 20% of patients walking around have severe IJV compression and don't know it. That's on both sides. And if we go to moderate compression on one side, that's about 1 in 3 people walking around. So IJV compression isn't a problem. Now, when it can become a problem is when things move around and there's instability and C1 pushes too far forward during motion. So you're not really trying to pull the C1 back as much as you are trying to stabilize that area and prevent that compression. AT, if you're dealing with post-PICL, would it be equally beneficial to continue cutting diet 20% in addition to strong recommendation supplementation pre-PICL protocol? I think what you're talking about is a little bit of intermittent fasting there maybe, or calorie restriction. Calorie restriction can be very positive, but you'd have to make sure to get good nutrition. So it's something you probably want to do before, right? If most of us, hopefully, if you're not a big overeater, if most of us cut our calories by 20%, we'd lose weight, not rapidly, but we'd lose maybe a pound or 2 a week. So that's something you could do. Now, the thing is, you need to make sure you substitute that with high protein, and also make sure that you're taking all your supplements, etc. So you're not getting into a malnourishment situation. But assuming you're not getting into malnourishment, then I think it might help control the inflammation. Better to do before the procedure than immediately after, however. Amen. Is supine flexion extension CT, would it be able to diagnose CCI, help supine, MRI flexion extension, mouth, bended x-ray? Yeah, all of those things are helpful. They're not going to be as good as the DMX, but I think, as I've said before, if you're outside the US, it's always helpful to see these studies. Flexion extension CT would be helpful. Flexion extension x-rays are helpful. CTA, not as helpful. Open mouth, AP open mouth, lateral bending x-ray, assuming it's done correctly, is helpful. All of that provides helpful data. Daniel, why are some responding better to regenerative medicine than others? Yeah, Daniel, I think it comes down to lots of different things. As I've said before, my personal sense is, number one, we've got patients who are discovering 10, 20 years into this that they've got CCI. So there's a percentage of those patients that get permanent neurologic damage during that time. So they're really unrecoverable as a result. We've also got patients who are have systemic inflammation, et cetera, so they're not going to respond as well to a regenerative procedure. Or we've got patients with too much damage where we're just not able to rescue those ligaments because they're just beyond repair. Those are probably the biggest things we see. And then we've got patients who are centrally sensitized, as I've talked about before. I've called these fragile egg patients. And those patients are in that scenario where it's really hard to treat them because anything you want to do is going to flare the heck out of them. So you're constantly walking on eggshells with that patient, trying hard to help them without causing them to flare up. It's been advanced by DB. Is it true that CCI can cause anxiety and depression? Is it true would be treating CCI resolve those issues? It's certainly possible that CCI through vagus nerve irritation can lead to a fight or flight response. So that might be termed anxiety. Depression is pretty common in chronic pain patients. So it's not unique to CCI at all. We see a lot of chronic pain patients that move into depression because of changes in life, dealing with the chronic pain, et cetera. As far as if we treat the CCI, will all that go away? It may or may not. If you've had this issue long enough and severe enough, there may be permanent damage to the vagus nerve. So the anxiety may or may not go away, although we've certainly witnessed a lot of patients recover from that just by treating the CCI. As far as the depression is concerned, sometimes that needs to be chemically treated before that'll improve. And sometimes it will go away as the patient's pain calms down, as it would be if you had chronic back pain, et cetera. Paul, I was wondering in general how often I can get PRP, and if it hasn't worked, after how many, what's the next step? Paul, I don't know what it is we are treating with PRP in that question. So I need to know a little bit more about what's getting treated there. It's been advanced by Gerald Brownstone. If you had CCI for several years, but have been fairly functional, is there a chance that your procedure will help? Yeah, so that's more on that 7 out of 10 patients who we can help. That means that 3 out of 10 patients we can't. And as I've said before, the more severely functionally disabled the patient is, the harder it is to climb out of that much deeper hole. You're telling me that you've been fairly functional, so there's not a lot of high functional disability in there. And so several years, that kind of patient, good outcome. But again, I don't really say anything to my patients other than we can help about 7 in 10. Daniel, what do you think of that case study? Not quite sure what you mean, but what do I think of that case study? A case study is information published on a single patient. Maybe you're talking about a case series. And I think if you're talking about a case series of non-responders, certainly looked at that. I haven't seen any MRI or imaging reason for that. Now, if you're talking about a case series of non-responders that could look at all those other things, sure, that's a good idea. Levon, hi, Dr. T. I have a PSCL scheduled for 30th of August. Could stomach ulcers be clinically significant? Blood work is fine. Hemoglobin, hematocrit are high. Iron is low end, but within reference. I don't think it's going to make a difference other than if the treatment they're prescribing is a medication that's restricted. So, for example, I know they use a lot of triple antibiotic therapy now for that, as well as proton pump inhibitors. The proton pump inhibitors may or may not have some effect. Different antibiotics can have different effects. So, for example, if you were on a quinolone antibiotic, that would be a no-no, that kind of thing. Stable on 3, is it okay to use an infrared sauna after PICL? Is there any amount of time that someone should be cautious around heat? Generally not a problem if we're talking about an infrared sauna. Mehul, inside pronation of knees, medial compartment knees, close, bone marrow through PRP's booster after 1 year, not showing much improvement, looking for practical knee replacement, maybe KR procedure. Would have been good to add hyaluronic acid as a route issue is less meniscus cartilage between the knee bone medial compartment, patient in pain after 1 year and have a little off. I don't know what question I'm being asked here. Certainly hyaluronic acid can help some patients who have that kind of osteoarthritis. If you're asking, would it be helpful to add hyaluronic acid to a PRP shot? There's some research that shows it could be. There's some research that shows it doesn't make a difference. In total, I would say right now we've got more research that shows it could help. So I think there'd be no reason not to add, for instance, HA to PRP for that kind of knee arthritis. Daniel, how many people have had PICL since you invented it? We're up to about 1,200 procedures. As far as patients go, that's going to be around 400 patients, somewhere in there. Could be slightly more because more of those people would be having first procedures. So I take that back. Maybe closer to 500 or 600 is the N number of patients, 1,200 procedures. James, do patients ever have difficulty flying home after a PICL procedure? Usually not. We'll certainly sometimes have to support them. Every once in a while, we'll see a patient that delays their flight, but that's pretty uncommon. So in general, not, but that's as long as they sort of follow the guidelines and don't get too crazy, meaning we'd want you to stay if you're domestic for an additional day afterwards, so we can see you in the clinic if needed. If you're not domestic and you're international, then you should stay 2 or 3 days before you fly home, because that's a much longer, harder to deal with flight. James, how common it is for CCS to cause gastroparesis, CCS or CCI to cause gastroparesis or digestive problems or stomach pains? We certainly see people that have digestive problems or gastroparesis as a result of CCI. It would be the minority of our CCI patients, but it's not uncommon. Duck P, hello, any possible explanation as to why activating my upper thoracic muscles seems to make my head feel more stable on my neck? What muscles am I activating that are causing this? Probably either the levator scapula or the upper trapezius. Yeah, that would be one of those two. Russian, is it possible to come see you in Colorado for a CCI assessment? Does your clinic have a DMX and MRI? Russian, certainly possible to see us for a CCI assessment. Just realize that if you're going to be planning on any kind of treatment, you would need to make sure that that's scheduled as well. Or if you just want to come out for an assessment, then obviously no treatment needs to be scheduled. But it's pretty rare that we can accommodate someone for treatment if they're coming in for just an assessment. So just realize that that's the limitation. DMX, we send those out to Dr. Katz's office. MRIs, really depends on the type of MRI we're getting. And that could be one of 3 or 4 different kinds of MRI. So we send all of that out. Mehul, spine, L5 vertebra up here, sacralized, changes of, we got all that. Is there any spine stem cell useful? What is the risk of spine since many nerves come there? Is spine issue from knee, vice versa? L5 is spine, can it become unsacralized? How long can it take? Success rate. Again, Mehul, I can't answer these questions without doing a telemedicine. If you're interested in doing a telemedicine, then reach out to my office and we can certainly get your history. I can look at all of the MRIs and give you some idea of how best to proceed based on that information. As far as the L5 vertebrae being sacralized, that's not an issue. You were born like that. As far as degenerative disc disease at L3-4 and L4-5, we can generally treat that using a functional spinal unit approach. That's usually a platelet-based procedure, X-ray guided, contrast confirmed injections combined with ultrasound injections. As far as nerves coming out of there, absolutely, the doctor needs to know how to mitigate all of that and needs to have extensive training to do it. So that's why you'd want to stay away from someone who's sort of sticking the needle in their blind, or someone who's just using ultrasound to do a lumbar injection, both of which would be inappropriate. You would need ultrasound and C-arm fluoroscopy with contrast confirmation to do it safely and maximize patient safety. Amon, I saw on my 3D CT IJV is being compressed at C4 level by the SCM muscle. Is that really a thing? Could explain dizziness and numbness. Unlikely to explain dizziness and numbness. Dizziness wouldn't even be an IJV compression symptom. More common IJV compression symptom would be tinnitus, for example. Submitted advance by Sherry Winston. If you have shoulder issues that occurred around a month after CCI without any trauma, would treating the CCI usually help the shoulder issues? They could. Also, sometimes patients have independent overlapping shoulder issues, so we may need to treat the shoulder as well and take a look at that separately. What does 0 equals facet overfill into epidural space mean for the PICL document form? Yes, all that means is that we injected the facet joint, usually in the mid to lower cervical spine, with the intent of the injectate, usually platelet lysate, nanogram dose dexamethasone, and ropivacaine, which is an anesthetic, going into the epidural space between the nerve and the disc, rather than injecting the facet joint itself. Magpie, are there any specific neurologic symptoms that are indicative of needing PICL as opposed to regular posterior prolotherapy? No, Magpie goes much more as to what kind of CCI you have. There are 8 different kinds of CCI. And so the kind of CCI dictates what needs to be injected and how. So neurologic symptoms won't get you there, but certainly imaging and an evaluation by an expert can. So for example, if you have CCI2B, it would be the alar ligament, that's the priority. CCI2A, the transverse ligament, that's the priority. CCI3A, it would be the posterior ligaments back here at C23, that would be the priority, etc. So it's not neurologic, it's based on which type of CCI you have dictates whether or not posterior prolotherapy is going to be able to do anything at all for you. Duck P, do you treat patients with PICL or posterior PRP who have MCAS? We don't generally use PRP in PICL. We do use it a lot for posterior injections. MCAS shouldn't make a difference in all of that. Rishi, have you seen patients get results improvements even though they have had CCI for 10 years plus? For example, a patient with CCI for 10 years old, or maybe the CCI is 10 years old, they got progressively worse, so the patient was highly functional and pushing through headaches, pain. We have, but as I've said, just realize the longer you've had this, the concern would be that there could be some accumulated permanent damage to the neurologic structures. Now, obviously, a better story for that patient would be someone who was functional, pushing through the pain, and then more recently got worse. That's very different than someone who became disabled from this 10 years ago and is continuing to get more and more disabled over time. Duck P, have you treated moderate UCL laxity, no tears, the PRP? How many treatments have typically taken a young patient? Yeah, moderate UCL laxity is pretty easy to treat. That's an ultrasound guided injection into the ulnar collateral ligament. Usually it's just 1 or 2 PRP treatments in a young person. Paul, Dr. C, for my neck and upper back, 3 mini bulges in cervical and 3 in thoracic. There's nerve issues causing tingling and burning in the neck, back, and chest and throat area. Had epidurals and worked great. So I think Paul is referring to PRP way back here. So running journal Hoffman, can I get PRP? And then going back to this question, Dr. C, from my neck and upper back, 3 mini bulges, cervical and through. There's nerve issues, tingling, burning in the neck, back, chest, head, epidurals, and work great. Yeah, so how often can you get PRP in that situation? There's really not a limit like steroids. Steroids damage tissue, so we don't want to put steroids in more than a couple times a year. When it comes to PRP, there's not that same issue, but there is a practical issue, right? I would expect that somewhere between 2 to 4 treatments should get you where you want to go. Now, we do have a few patients that are so severely damaged, if you will, that they come back in once or twice a year, and we just treat them on an ongoing basis with PRP. But hopefully that gives you an idea of what we're talking about. Dr. Centeno yesterday had a local AO for new x-rays and adjustment. My cervical curve is improved and my atlas is misaligned the same way as before, but to a lesser extent. I felt immediate improvement in some symptoms and also neck range of motion after the adjustment. Previously, adjustments would not make any difference, so I'm happy for signs that instability is improving. I know that I'll most likely lose adjustment in a week or two. Should I keep repeating the same adjustment? Yeah, Liam, it sounds like that you're on a good path there. And, realize that when something is super loose and sloppy, it's just going to stay out. But as we start to tighten up those ligaments and they're not fully tightened, it's going to stay in more often, but it still may pop out. So all that sounds very promising as a result from that first PICL procedure. So thanks for that update. Mehul, I was asking what can be done since few days a week. Pain comes while walking at 10, not walking DOA. Patient thinking surgery at permanent solution. What else can be done? Yeah, Mehul. So again, best thing to do would be a telemedicine appointment. I can't give you specific advice over the internet by just typing in kind of what's on the images. David, curious doc, what are your thoughts on massage therapy in general? I think in general, if it helps, continue it. Really no issues, problems with massage therapy, etc. I think even better if it's really deep work, focusing on getting and restoring fascial balance, which is really great stuff. So more along the lines of Rolfing through Ida Rolf's work, or myofascial release through John Barnes' work, that kind of stuff. Daniel, how is it with placebo, with regenerative medicine? How many improved overhang numbers have you seen? Lots and lots of improved overhang numbers. I don't know the total number at this point. We look at improved overhang or just repeat overhangs on C1, C2, open mouth lateral bending DMX. When we're just trying to figure out whether or not this person made any improvement. Now, that's only maybe 1 out of every 5 times that we do that. But certainly I've seen now 100, 200 of those follow-up images, somewhere in there. Liam, have you done a PICL on a patient that had vertebral artery collaterals? Would this increase the risk of PICL? Just curious. Shouldn't increase the risk of PICL for sure. May or may not slightly increase the risk of something like a 0-1 injection. But most of those collaterals are going to be pretty small, so generally not a huge concern. Era, is it true that neurologically turned off deep neck muscles by CCI don't respond to physical therapy or exercise? Well, yeah, a lot of CCI patients can't tolerate physical therapy or exercise. So so we certainly observe that. Liam, I have symptoms like visual snow, tinnitus, light sensitivity, which may be indicative of IJV compression. At the same time, I do not have exercise intolerance or brain fog, so may suggest only any IJV compression is not that severe. Should I try to do some specific work for IJV compression or just focus on improving CCI? I think right now, Liam, what you're telling me is focus on CCI, and then obviously as things progress, we can add in other parts and pieces. Okay, let's see. I got to skip over Mehul here. Mehul, you really need to do a telemedicine eval. Caleb, how is it even legal for a naturopathic doctor to be allowed to perform fluoroscopic regenerative injections? Like it's crazy how it takes formal hospital training and they just skip that. Yeah, Caleb, I would agree with you. And I think it's mostly not legal. For example, I reviewed this pretty extensively in the Utah Naturopathic Practice Act. It seemed pretty clear to me in the Utah Act it was not legal, that there was nothing in the Utah Practice Act that talked about using X-ray guidance to guide a needle. And in many other practice acts, you've only got authorized, quote, minor surgery, which is considered something like suturing. So suturing a laceration or lancing a boil. But certainly none of these practice acts I've ever seen on the naturopathic side have contemplated doing these sorts of spinal procedures. So you're right, they're likely highly illegal in all of these states. Now, the hard part there is getting the medical board to bite. Normally, the medical board is dealing with so many different parts and pieces that they just don't take the time to go after this kind of stuff. So that's been the issue we've seen. Now, I have seen that the AMA has started to look at what they call practice scope creep. And hopefully they'll be looking at this very issue, because we're seeing this scope creep, it's called, meaning the scope of practice by the people who don't have the training to do these things gets a little bit bigger each year. And as long as it goes unnoticed and unchallenged, it just continues. So you're right. Does a naturopath have the kind of hospital training that would be necessary to make it safe to do these procedures? They do not. There's nothing even close to adequate training there. Could you even go to and get trained by a competent MD who went through fellowship training or other training to do these procedures? You really couldn't. So you bring up an excellent point. Why this continues? It continues because the medical boards are a bit asleep at the switch. The good news is the AMA is starting to focus on scope creep. Okay, guys, so we are coming up to an hour, and I do have a 2 o'clock meeting my time mountain, so I'm going to start to wrap this up. We talked today about what happens during a Chiari decompression surgery, how a mesh is placed back here where the bone is taken out at the back of the skull, and how that can put patients at risk who get blind posterior injections, things like occipital blocks, or even prolotherapy through that midline upper cervical area. So anyway, I will be here this Monday. So we'll be doing again this whole thing again on Monday, different topic, same bat time, same bat channel. So I will see you on Monday. I want everyone to have a fantastic weekend, and thank you so much for all the great questions as usual. Thank you.